as Donna said, I'm a haematologist. I'm actually we've got a unique situation here where the hospitals are all one in the precinct. So I've got a joint appointment at the Royal Melbourne Hospital and Peter MacCallum Cancer Centre. As she's mentioned, I'm both at the University of Melbourne, actually also at the University of Sydney as well. And I have quite a number of things that I do, but one of the main things pertinent today is I am the lead haematologist in the late effects and survivorship service, which is here at Royal Melbourne Peter MacCallum, with a clinic that we have once a week at the Peter MacCallum for patients who have had chemo and radiotherapy for cancer and for late effects. So we see patients who have had treatment any time from 5 years ago right through until we've got some patients that are sort of 40, 50 years post their original cancer diagnosis that we're seeing for late effects. So it's a really interesting area, really inspiring clinic in many ways. And it's really interesting to see how treatments have changed over the years as well, because of course the people that were treated 40, 50 years ago have got side effects from treatments that we're not seeing today, and I'll touch on some of the relevance of that a bit later. So I'm here today to talk a bit about late effects and survivorship, and I'm going to very much put my medical hat on and talk very much about a lot of the very medical sort of side effects in many ways, because the other, probably in many ways more important side effects, particularly the fatigue, the sleep disorders, all those sort of things are being very well covered by other people later. So I'll talk a lot about the medical type of things. So this is sort of just an idea of what I was going to cover this morning. I just want to talk about, why are late effects important? And they're often not covered very well when we start the journey with patients with lymphoma. And I also do a lot of patients with lymphoma. I also do a lot of lymphoma treatments and lymphoma clinical trials. And in the busyness of originally talking, when someone's originally diagnosed, sitting down and talking about all the potential late effects is often very summarily glossed upon or not touched upon very much at all. How do we talk about late effects? What are the main ways we think about late effects? And then what sort of an approach to the different late effects through that? And then sort of finish up with what I think, as a someone who works in this field, what every survivor should be sort of thinking about and knowing about their own particular treatment and risks. So what are late effects? So late effects are really any chronic or late occurring effect, adverse, either it can be medical, it can be a psychosocial effect, it can be a complication, it can be a disability that develops or persists following cancer treatment. So it could be that you've got peripheral neuropathy, so the tingling in the fingers and the toes that you got on your second or third cycle of CHOP chemotherapy, but you've still got it 5 or 10 years later. That's a late effect. Or it could be that you have heart failure that occurs 20 years after you had cancer as a late effect so you've been well for that time, but something happens new many years down the track. They're all late effects of the cancer treatment. Fortunately, these days, the survival rates for cancer are very good. They're much higher for children than they are for adults, but they're still very good. So there's a lot of people with late effects, and it's actually estimated that there are around 1 million cancer survivors in Victoria at the moment. So that's the sort of numbers we're talking about, and that doesn't include just little skin cancers, but real cancers, cancers that have chemotherapy, radiotherapy. And so there are over 10 million cancer survivors in the USA. So worldwide, when you start to think about the scope of this problem, it's really significant. And the estimates are really vague, but it's around 1 in 640 people as a survival of childhood or young adult cancer where the best data is, but it's estimated that up to 1 in sort of 150 or so people might be a cancer survivor, as particularly around this time and as time goes on. So it's quite a significant problem. So this is sort of some of the numbers, and I think this is the Cancer Council Victoria numbers, and this is all comers. The overall chance of surviving at least 5 years from a cancer diagnosis in Australia is 68%, and this is at the end of 2012. Unfortunately, the statistics data comes out quite late, but there were 410,530 cancer survivors in that 5-year period. And you think about that just adding up with all the survivors going out many years. So who are the cancer survivors? So 64% will be beyond, when you think about all of the cancer survivors out there, more than 64% will be beyond 5 years post-diagnosis. the majority will be elderly, which makes sense in the sense that most cancers are diagnosed as people are in their older years, more mature years. But it's estimated that will come down to 1 in 18 Australians by the time we get to 2040. So that's huge. And that doesn't include those non-melanoma skin cancers. So late effects, I've already touched on this. Late effects can be very practical things. They can be the fact that you've had surgery and you've got pain related to surgery, or lymphedema from removal of lymph nodes or something like that. They can be side effects directly related to chemotherapy drugs or related to radiation treatment. They very much, though, can also be psychological. So something like post-traumatic stress disorder, which can often be associated with, originally was described in survivors of World War II, for example. Very common in patients who've had cancer treatment, flashbacks, nightmares, things along those lines, anxiety, depression, all very much late effects of cancer treatment. But they can also be very practical. So, if anyone's tried to get even just travel insurance or, health insurance or life insurance or anything like that, that is a late effect of cancer treatment, in that it is a disability or impediment or a problem that occurs as a relation to your cancer. So whilst it's not a physical late effect, it can be a problem. So this can even relate to, employment issues. So there's a lot of statistics, not so much in lymphoma, but in patients who've had either childhood cancers or in allograft transplants, around being re-employment of younger people who had cancer treatments. And the numbers are way down, and not just because of a physical disability, but because of the interruption in their career and the problems with fatigue and things like that ensures. And there's a glass ceiling comes when you've had cancer, almost. So there's a lot of different issues that can be classed as late effects of cancer treatment. So the best information on this is from the USA, where they've looked at big cohorts of survivors of childhood cancer. And so we don't have a lot of good information about lymphoma specifically, and we don't have a lot of good information about late effects and survivors in adults who are treated. So just looking, though, as an idea that when people were treated as children for cancers, which are mostly leukemias in children and some sarcomas, but some lymphomas as well, by the age of 45, you can see that 95% of adults who, at the age of 45, who were treated as children or adolescents for cancer, 95% of them had some chronic health condition that was related to their cancer. So when you think about that, that's quite astounding. And 80% of them were serious or disabling, that required, some sort of a life-threatening or chronic condition that required major, treatment of some sort. So the risk of specific problems were quite different. But what you can see here is that, and probably what's striking in these graphs, is you can see that these problems, the kids had cancer between the age of 0 to 15, but the majority of the problems were occurring up around the age of 30, 40 and plus years old. And, these graphs, just get higher and higher. So there's, breast cancers, heart valve disorders, pituitary, which is the hormone generating organ in the brain there, and hearing loss. So, it's just a snapshot and an example of how big and how serious the problem is, and how the fact that this actually gets worse as people get older. So there's no sort of ceiling unfortunately, to the limits of late effects as people do get a little bit older. And that's important to understand, and it's important to understand so as survivors you can be empowered to know about it, know what the risks are, and be ready to be proactive and deal with them as they come up and prevent them becoming major problems. The other important thing to note is that these late effects do shorten the lifespan of cancer survivors. And this is, again, looking at children who had cancer and as they were adults. So, again, we don't have a lot of data from adults who had cancer. The studies just haven't been done. But what we can see is that the excess risk was around 8 deaths per 1,000 person years. So basically, you can see here that that's the US population up the top, pretty straight line for males and females. And you can see these are survivors of childhood cancer. And whilst there'll be some deaths there related to their primary cancers, because of course, unfortunately, as we know, cancers can and do relapse, the majority of the deaths, particularly when we're going out years since diagnosis, post 10 years, 15, 20 years, will be due specifically to late effects from cancer. So this is a big, significant problem. And then how well are cancer survivors? So, they're 2.5 times more likely to have poor health, 1.8 times more likely to have some form of mental health problems, more likely to have limitation in ability to do normal activities, and likely to have a functional impairment. And functional sort of how well we go about our normal daily lives. However, what's actually really interesting, and this has actually been borne out in some adult cancer studies, is that the actual survivors themselves don't report that they're in poor health. So they actually have, and often have perspective related, very much it's thought back to when they were at their sickest or in their illness, their cancer story. So as compared to, peers who haven't had cancer, they actually feel that they're equally healthy, whereas clearly when you look at the medical statistics around, they're not. So only 11% of them reported they were in fair or poor general health as compared to good general health. So it's interesting around perspectives, and that perspective sometimes leads to people not being as proactive and as well informed as maybe they could be around some of their cancer treatment, because there's probably an element of denial there too. So when we think about late effects, we think about them mostly by the type of treatment people had. So we would group treatment loosely into chemotherapy, radiotherapy, immunotherapy and surgery. Surgery is fairly limited in lymphoma. It's usually only used for biopsy purposes, although some people need to have surgery for complications of their original treatment. But certainly chemotherapy, radiotherapy and immunotherapy would be standard therapies for many patients with lymphoma. But we also talk about it by the site or effect. So chemotherapy affects the whole body, of course, because chemotherapy affects the whole body, whereas when we're talking about radiotherapy or surgery, for example, we're talking about the actual site that was affected directly, and that has implications there too. I'll go through this in a lot more detail, but when we're talking about chemotherapy, we talk about chemotherapy drugs in classes of drugs. So a class of drugs is a group of drugs that works the same way, so has the same type of action. So, we've got, and I'll talk a bit about this class particularly, so we've got this class called anthracyclines. So anyone who's had R-CHOP chemotherapy, in CHOP you've got the drug, which is one of these anthracycline drugs here. You've got something called doxorubicin. We have the alkylating drugs, so we've got the common one for lymphoma might be cyclophosphamide, so that's the C in CHOP, or the ifosfamide, which if anyone's had ice or rice, anything like that with their chemotherapy, that's the I in ice or rice, for example. So the alkylating agents are another type of drug. And then we go on to all the different drugs. Bleomycin here is commonly used with ABVD for Hodgkin lymphoma, for example. So the different drugs come into different classes, and each class has sort of a class effect. So it's generally each class of drugs has a similar effect. So all the anthracyclines have the same type of toxicity, for example. So, for example, how as a doctor we would approach the late effects is we would step through the type of chemotherapy someone has. So I've done this here with ABVD, which is a very common type of chemotherapy given for people with Hodgkin lymphoma, and it's usually given for early stage Hodgkin lymphoma. And so the drugs we use here are, for example, doxorubicin. That's an anthracycline. Its potential late effects are cardiac toxicity. The type of surveillance we would do is here, and then the health promotion we would do is here. And that's sort of just an example of how, when we step through looking at this from a medical point of view, how we would sit down and look at what the potential late effects are from a chemotherapy point of view, for example. And I'll go through in a bit more detail some of those. The radiation therapy in children, particularly, or young people, radiation stunts or affects growth and development, so we try and avoid it wherever possible, whereas when it's given as an adult, hopefully all fully grown, it shouldn't do that. So the toxicity with radiation very much depends on the age at which you had the actual treatment. The younger the age, the higher the late effect rate. But it also depends on the total dose given and also how many fractions. So if anyone's had radiotherapy, you may or may not be familiar with the fact that radiation's given as we talk about a total dose, a certain number of grays, which is the radiation dose, and then how many fractions, and each fraction's over how many days. So say 20 fractions, so say 40 gray over 20 fractions, that means you had a total of 40 gray dose over 20 days. And those 20 days are usually Monday to Friday times 4. And so the more fractions, so the more spread out it is, the less the toxicity, whereas the more intense the dose is at any one time. So if you give, say, 40 gray in 2 fractions, for example, it's going to be much more toxic both then and also in late effects than it would be to give 40 gray over 20 fractions. So it's important to know how it was given and how spread out it was as well. And then it also depends with radiation where it was. So some organs are more sensitive and some are much more resistant. So it's very easy to say with radiation that, there's some areas that particularly are quite resistant. So, limbs, for example, if you have an arm or a leg radiated, we need to watch for the skin, but otherwise it's not going to cause bones or other problems with those. Whereas, for example, the brain's very sensitive, the heart's very sensitive, the lungs can be sensitive, for example. So, it's always important to know exactly where, and when we look at that, we need to look at the actual maps of the fields because we need to know exactly what was radiated, but what was also in the zone of radiation as well, what organs might have been touched by radiation that weren't intended to be radiated. And so then that's about the amount of normal tissue treated. So we need to look at the actual mapping of the radiation. They have these very sophisticated 3D maps of the body they do on the scans, and we look at exactly the spot that was radiated, but then what was in the way of that radiation. Was it a lung or a heart or something like that? So we know what we're looking at. And then whether concurrent chemotherapy was given. So if you give chemotherapy and radiotherapy at the same time, the acute toxicity and the long-term toxicity is worse than if you give them at separate times. So that's important to know as well. And then also knowing if the person who had the radiotherapy had any underlying medical problems that could affect that. There's particularly some genetic diseases that can make long-term effects of radiation worse as well. And these are all taken into account at the time people have radiotherapy planning, but it's important as for late effects that we understand all of those as well. So, for example, when we're looking at radiotherapy, a common area to have radiotherapy is in the mediastinum. The mediastinum is the chest, the middle of the chest. And, for example, there's potential impacts if the breasts receive some radiation for breast cancer, particularly in women. Lung, there's toxicity to lungs, heart, and the thyroid gland, which is up here in the neck. So, again, we need to look carefully at exactly where it was radiated and all of those potential risks. So when we're talking about approach to care, and I should have actually taken out AYA, sorry, I've used that in another talk, but to any cancer survivor, we're talking at a very systematic approach. So we can't just take looking at just the chemotherapy or just the radiotherapy or just the location of the cancer. We have to look at the whole person. We also have to look at where that person sits within their community and within the health system. And it's particularly important that we use that health system to maximise the outcomes for everybody. So it's really important that we have the patient and their support people at the centre of our focus, but that we're working very much with the cancer specialist who was involved in their original care. We're working very much with the GP, with community supports, and also with the cancer survivorship nurse. And so you sort of see here our sort of plan that we're linking in with all the different elements, and it's particularly critical that at the centre of that is the patient and their supports, be they family or friends or whomever they have as their main support people. It's really integral that we have a GP on board. So the main person for survivorship care should be your GP. And the aim of services like ours here at Peter MacCallum in specialist centres is to empower both the patient, their families and the GPs to go forward with that care, with us as a backup and an open door policy, but not to be in the hospital every 5 minutes, but to really be using us as a reference centre, for example. Ideally, patients should have a care plan formulated at the end of their treatment that goes through all of their longer term what treatment they have and all of their potential longer term risks, and then at various points we'll touch base back with that plan with the specialist centre and with the GP. And then the plan should also involve, as well as what the risks are, but what strategies can be done to minimise those risks and prevent any future problems where possible. So again, a very busy slide, but this is again from a medical perspective how we're taking a whole of person approach. So we would be looking very much at what could be all the side effects, of the cancer treatment that people had, and as you can see, there are many, many different ones. Putting that all together as part of a care plan and thinking about what every time we see someone, every time a GP sees someone, what things do we need to be thinking about watching for. I think one of the main take-home messages, though, is that every person is unique. So you may have known or seen that you may have met someone that had the same cancer, maybe even the same treatment for the same lymphoma that you had, but your experiences are different. And that's because everybody is different, So when we would treat multiple people with lymphoma every day, for various reasons, people have different experiences. It could be, different backgrounds, different other medical problems, different variations in their treatment, different doses of treatment, different locations of tumours, all sorts of things. So it's really important to remember that no two people will have, just like no two people's cancer is exactly the same, no two people have the same side effects from the same treatment. So it's important to say, and you will see some people that have no side effects long-term or say all through treatment. It just looks like they have a fantastic time. And then other people having exactly the same treatment have a terrible time. And the same with late effects. So just talking about specifically what are some of the late effects that we think about and what can we do about them. So these are up here not to scare people, not to be worried. The vast majority of people get very few of these side effects, but these are some of the range of side effects that can occur in patients who've had lymphoma treatment. And as you'll see, there's an overwhelming number of them, but most people will get very few. Probably the commonest central nervous system general problem is actually fatigue, which I haven't listed up here because it's not whether it's a central nervous system problem or a general problem. But what we can certainly see, particularly in people who are treated at younger ages, are developmental delays, but poor short-term memory and memory problems are very common in people who've had any form of cancer treatments. Poor executive function. So executives are those really fancy higher level functions of the brain that allow you to multitask and do fancy things. Seizures are quite rare but can occur. And cerebrovascular events, by that we mean stroke, essentially. Again, are slightly increased if people have had cancer, but this is really in people who've had particularly brain radiation rather than chemotherapy in that effect. You can get a problem called myelitis with the spinal cord and hearing loss. Again, they're specific to certain chemotherapy agents, not everybody. And you can also have problems with the vision with the eyes. So the eye problems are largely due to radiotherapy that's affected the eyes, and you can have problems such as something called glaucoma, or you can have cataracts. So cataracts are quite common in people who've had radiation that's affected the eyes in any way, and cataracts are usually easily managed and treated. But are clearly a problem. With the muscles and the bones, generally these are fairly immune to the effects of chemotherapy, but if you've had radiation, you can actually have reduced growth or wasting of the bones and muscles in the area you've had radiation. So, for example, someone like this chap here has had it sort of hard to see, but you can sort of appreciate there's wasting of the muscles around the shoulder and scapula there, because the muscles have trouble growing after a high dose of radiation treatment, for example. So that can be, create asymmetry and long-term problems with pain and mobility and use, particularly of arms and legs, for example. And if you have radiation at a young enough age, you can have short stature and chemotherapy as well. So be short. But then, and this just means there's hormonal problems that can contribute to that as well. So talking about hormone problems are a relatively common side effect of many cancer therapies. So the pituitary hormone is a hormone, a gland that sits just at the base of the brain there. It can be affected by radiation and sometimes chemotherapy. And it produces things such as GH, which is growth hormone, and so you can have a growth delay, again not affecting so much in adults because we're hopefully already grown. TSH is a thyroid hormone, so you can have low thyroid hormone there. These are the hormones that affect in women ovarian function. So you can have what we call premature menopause, which is actually a reasonably common side effect of many chemotherapies, rather than actually infertility certainly occurs directly at time or around the chemotherapy, but one of the problems that can occur is something called premature menopause. So menopause is normal anytime after the age of 40, but if it occurs before the age of 40, it's called premature. And so if you have treatment at a younger age, it's not uncommon to have menopause before the age of 40, and reduced fertility in general. And then you can get a problem called diabetes insipidus, which is a bit like diabetes in that it's a sort of more complicated version of diabetes, but it's a specific problem where you have a lack of a hormone called ACTH. It's relatively rare. Thyroid problems are also very, very common, and you can actually have, particularly if you have radiation to the thyroid, you can have problems where the thyroid doesn't function properly. Probably one of the most common problems related to any cancer treatment is metabolic syndrome. So metabolic syndrome is actually very common in the community. And metabolic syndrome is a catchphrase that's been probably popularised over the past 5 or so years in the medical community. And it describes the problems of hypertension, so high blood pressure, polycystic ovarian syndrome in women, heart disease, dementia, that's fatty liver, that's all trendy terms, insulin resistance, which is sort of the pre-diabetes problem, high cholesterol, and type 2 diabetes. And this sort of conglomeration of symptoms of diseases comes under this catch of metabolic syndrome, and it's associated with what we call central adiposity. So fat tummies is sort of the way to talk about it. And you'll see, in general health, a lot of, the Heart Foundation and people promote avoidance of a lot of these risk factors there. And so metabolic syndrome is very strongly associated with anyone who had any form of treatment for childhood or adult cancer, and the studies are very strong showing this is a very high risk. Particularly if you've had radiation to the brain, that makes it much more at risk, but really it is at risk of anybody who's had any treatment. We don't really understand why it occurs in most, particularly in people who've only had chemotherapy. It's really not understood. It's thought to be an effect to the hypothalamus, which is an organ inside the brain that kind of controls our body's metabolism in some way. And then the other effect is if people have had radiation to the pancreas, which is quite unusual to have, but it does happen at times. And so that radiation can also cause dysfunction of the pancreas and can cause an increased risk for this metabolic syndrome. So people tend to have what we call central obesity, which is the abdominal obesity, high blood pressure, high cholesterol, and diabetes or pre-diabetes. And what's really important about metabolic syndrome is a lot of things you can do to actually prevent it and treat it, which you can be proactive about. So that's why a lot of talk is about the metabolic syndrome. Heart disease is also a common risk after lymphoma treatment and cancer treatment. And particularly this relates to the class of drugs called anthracyclines. And anthracyclines include drugs like doxorubicin, adriamycin. You see them very commonly in lymphoma treatment because they are one of the most effective drugs for lymphoma. And so, for example, CHOP chemotherapy, ABVD, BCOP all contain anthracyclines as an example. The other risk for heart problems is if you have radiation to the heart that affects or is anywhere near the heart as well. So the chemotherapy drugs tend to cause a disease called cardiomyopathy, which is a weakening of the heart muscle. The heart's really just a muscle that pumps, and that usually occurs within 5 or so years of having had the treatment, but it can occur at any time. And particularly risk factors are when the body's under stress. So the classic one is that a woman gets pregnant some years after her cancer therapy, and that stress in the body in pregnancy causes some heart failure. That's quite a common sort of scenario. And so it's really important we know about and monitor for heart risks in people who've had these diseases. The cardiomyopathy with these drugs is dose related. So it's important that at some point somebody calculates the total dose that you've had of these drugs and knows what risk category you're in and subsequently does the appropriate monitoring going forward. And it really depends on Everybody's different, but we have a good ballpark figure for most chemotherapy regimens. For example, if you had 6 cycles of R-CHOP at a standard dose, you will have a moderate risk, not a high risk of this, for example. We have a pretty good ballpark, but everyone's different, so it's important to have that calculated individually for each person. The coronary artery disease, so this is talking about heart attacks, are increased after radiation to the heart, much more so than chemotherapy. And then there's a number of other heart problems that can occur that are a lot less common. What's important to note, though, is that if there was any radiation to the neck, and again, this can be reasonably common in lymphoma if people have a node in the neck that's irradiated, there's really important arteries that run up and down from basically the heart up to the brain that supply all the blood to the brain called the carotid arteries. And they can become damaged from radiation, and that damage can occur 10, 20, 40 years post, and that causes narrowing or plaques in those vessels, which puts people at risk of stroke. So again, it's really important to know if you had radiation there, did it include a potential risk there, and to monitor that appropriate, because again, that's something we can monitor, catch early, do something about, and prevent major problems in the future. That can also contribute to high blood pressure as well. So the kidneys and genitourinary system are generally not a big problem in the late effects. They cause more problems immediately. So most people that have long-term effects from the kidneys and bladder, for example, do so mostly because they had the problems at the time of their treatment and they've not repaired themselves. So kidney problems, for example. Having said that, probably one of the biggest issues, and I haven't listed here, is people have very, very high dose cyclophosphamide are at increased risk of some bladder problems. But most of these problems happen, like, for example, the methotrexate, happen at the time people have the chemotherapy and they just don't get better in some people. Radiation can also result in significant problems if the kidneys are included, and some people have kidneys removed, for example, as part of their surgery for various cancers as well. Lungs are very sensitive to chemotherapy and radiation. The only drug that really causes significant lung problems is bleomycin, but bleomycin is the B in ABVD, for anyone who had Hodgkin treatment with ABVD. Fortunately, and because of this, bleomycin's largely being phased out in clinical trials now with a new drug, brentuximab, replacing it. And so I can envisage in 5 or so years, hopefully, that we'll start to see ABVD plus brentuximab as compared to bleomycin, and this problem will be gone. But for now, bleomycin causes these lung problems that occur in both lungs. It can actually often occur at the time of treatment or during treatment, and it can cause fibrosis or scarring of the lungs, and that can be a long-term problem as well. The other problem with radiation to the lungs is it can also cause scarring of the lungs, and it can also cause deformities of the chest wall. So you can appreciate this is a normal lung here on this side, on the right-hand side, but on the left-hand side here, you can appreciate that chest wall just isn't moving and hasn't sort of grown or moved normally. So the lungs get squashed in. There's no actual problem with the lung there, but it just hasn't got the room to breathe up as much as it should, and that can cause problems too. So gastrointestinal and reproductive systems. Gastrointestinal system has terrible side effects usually at the time most people have treatment, of course, nausea, vomiting, diarrhoea, or nodding, very common problems. But in the long term, we don't see generally a lot of gastrointestinal problems. They're usually related to radiation therapy directly to the bowel, and adhesions, again, scarring in the bowel, sometimes malabsorption if the bowels are very affected by radiation can be a problem. The reproductive system, however, unfortunately is quite sensitive to most chemotherapy, and so chemotherapy drugs can cause infertility directly by damaging both the ovaries or the testes, and radiation therapy directly can cause problems as well. It's also important if people have chemotherapy or radiation therapy at a young age, pre-having families, to note the damage potentially to the uterus. And so sometimes the uterus is important because, of course, it needs to carry a baby. It can't expand and do its job if it's been damaged sometimes by radiation therapy. So it's unable to support a pregnancy, for example. Even though someone might technically be fertile, their body's unable to carry that baby through for the full term. So there's lots of implications on fertility, not just the ability to not become pregnant. probably the biggest thing, and the thing we worry about the most, and the thing that I think worries patients the most, is the risk of secondary malignancy. And secondary cancers are relatively common after having had a cancer the first time. So we know that so this is incidence again in the childhood cancer survivors, because that's where we've got the best data, but the 30-year risk, so by 30 years after their original treatment, 20% have some form of cancer, some form, so 1 in 5 will have another separate cancer, likely related to their primary cancer and treatment. The ones that are malignant, so neoplasm's a word that means new growth. The ones that were malignant, around 8% or so were there, and non-malignant, then meningiomas, and I'll talk a bit about what meningiomas are and why they're important. So that's a 6 times increased risk as compared to normal people who hadn't had, I hate the word normal, but people who hadn't had cancer treatment there. And probably should say that this risk increases with time. So the time since diagnosis, it actually, increases. So by the time you're getting out to 30 years, that's where you get up to that high incidence. So the most common second malignancies are actually usually radiation induced. So radiation by far and away increases the malignancy rate much more than chemotherapy. The most common is called a meningioma. A meningioma is usually benign but can be malignant brain tumour, and that's an example of one there that arises from the meninges or the lining of the brain. And so for people who had radiation therapy of the brain, again, it's dose dependent, but the incidence is up to 40% at 20 years of people who had radiation to the brain. So it's very, very important if you had radiation to the brain to be monitoring these from about 10 years post the radiation. They don't occur quickly. These are things that occur later, with the median onset being around 20 years or so post your original treatment. Thyroid cancer is very common, and that's where the radiation has come to the thyroid. Skin cancers, anyone who's had radiation needs to be having an annual skin check on the area that was radiated. We all should be anyway, because we live in Australia and we're at high risk of skin cancer. But if you've had radiation, the risk of skin cancer in the area of the skin that was affected by the radiation is very high. So it's very important to have an annual skin check by someone experienced, like a good GP or a dermatologist, every year. Breast cancer is very common in women who have had radiation to the chest that is involved, some of the chest wall or the breasts, particularly if you were young. So the younger the age, particularly if you're an adolescent or a child at the time, the much higher risk of breast cancer in the future. Whereas if you were an adult when you had radiation, the risk is much, much less. And then probably one of the biggest risk factors is of blood disorders. So a disease called myelodysplasia, which is a disease where the bone marrow slows down and is not very functional, and also acute myeloid leukemia are common blood cancers that can come after chemotherapy treatment. And that's probably the biggest risk from many chemotherapy treatments, is the myelodysplastic and blood, and that's why people will do blood tests going out long term. So talking about this myelodysplastic syndrome and acute myeloid leukemia, they're related to 2 particular drugs. The first ones are the alkylators. So the alkylators are cyclophosphamide, busulfan, cisplatin and ifosfamide. Some of those names may or may not be familiar. Cyclophosphamide is the C in CHOP, ifosfamide is the I in ICE, for example. Usually these come at about 5 to 6 years post-treatment, so they're quite classic. They occur at that time. They don't occur earlier. They don't occur later. So once you're sort of 6, 7 years post and you haven't had one of these, the risk is gone. They usually have a myelodysplastic syndrome first that changes into an acute leukemia, and generally, unfortunately, they have quite a poor prognosis. Having said that, they're relatively rare. And then the other group is the topoisomerase 2 inhibitor-related AML. So this is things like, including things like, we don't use a lot of topoisomerase 2 in lymphoma, but the drug we do use sometimes is etoposide. Etoposide's the E in ICE, for example. These occur quite soon, so within 1 to 3 years post-treatment, and patients come in with just acute leukemia. They don't have a problem beforehand with the blood. And the prognosis is the same as if anyone walked in off the street with leukemia for the first time, which unfortunately is not always rosy, but is still a lot better than having a poor prognosis disease. So if someone has got to about 3 years post their treatment with these drugs, again, the risk of that is largely gone. So these problems tend to occur reasonably early as late effects. So this is just an example, picking out a disease. Hodgkin lymphoma is fairly common. So they have a high risk of secondary malignancy, and Hodgkin lymphoma survivors have been documented historically as having the highest risk of secondary malignancies, largely because in the past very heavy-duty treatments were given to cure patients with Hodgkin lymphoma. And the difference now is that, and this is the important thing to remember, is that particularly reading literature or reading internet, is that when we're looking at late effects, all the studies are looking at people who were treated 10 plus years ago, whereas people who are being treated in the last 10 years, the treatments have been refined and are usually a lot less intense than they were back then, because we know now, for example, we don't have to give as much radiation or as intense radiation, or we break it into fractions, or we reduce the doses of chemo or don't give as much chemo. So it's really important to remember when we're looking at historical information such as this, because if you're thinking, if we've got 50 years of information about these patients or 40 years of information about these patients, they were treated in the 1970s. Logically 70s, 80s, by having that information now. And the treatments then were very, very different to what we have now. So whenever we look at this information, we always have to learn from it. But it's all we can say is that we know that the risks now will be a lot, for people treated now, will be a lot less than these risks. Having said that, the risk is significant of breast cancer, with a 19% incidence at 30 years. And much higher if people were younger when they were treated. And then we've got the problems with thyroid cancer sarcoma, which is a bone cancer. Sorry, I shouldn't have abbreviated that. Colorectal cancer, lung cancer and gastric cancer. And again, all mostly related to radiation. Hodgkin lymphoma used to be treated with radiation alone, and that's the important thing to remember with this sort of information as well. Chemotherapy for Hodgkin lymphoma only came in about 30 years ago. So, for example, CHOP chemotherapy, some of the late effects, and just sort of thinking about some of the late effects we might get. So there's a risk of infection. That reduces, so that's obviously very intense at the time of treatment. That reduces over a couple of years. The heart toxicity, the risk is relatively small as the dose of anthracyclines is modest. So it's important to monitor with echocardiograms, which is essentially an ultrasound of the heart that's done. We do that post-treatment, then at 5-yearly intervals if they're normal. And if you're a woman who's potentially going to have children, it's really important to have one done before you get pregnant, and then during and then after pregnancy with those increased risks. Peripheral neuropathy, that's the tingling numbness of the fingers and toes from vincristine and vinca alkaloids, that group of drugs. That occurs at the time of treatment. It generally reduces over time, but many people are left with long-term effects with ongoing numbness and tingling, which can actually lead to a functional deficit. If you've got that and try to do up small buttons, for example, it can be tricky, or it can be painful walking, for example. But generally that reduces over time. Second cancers are a risk, particularly the leukemia and the myelodysplastic syndrome, which that risk is largely abated by about 6 years post-treatment. And monitor with the blood counts. The risk is higher if you are older at the time of treatment with those, and higher if you have other risk factors for cancer. So people who smoke have a higher risk of all of these problems. People who smoke and have cancer treatment are at much higher risk of the lung complications, for example. Obesity or a family risk of cancer also contribute to that risk as well. And then there's the risk of the metabolic syndrome. Again, that risk is higher if you're coming into treatment with problems such as obesity or smoking, plus things you can't change, such as a family history of high blood pressure or diabetes, increase the risk in any one person. So the transition to survivorship should begin at diagnosis, and particularly post-treatment is where we really want to focus on thinking about survivorship. So post-treatment survivorship care plans in an ideal setting should be delivered delivered and developed by the treating team, the team that's actually actively treating your lymphoma. And they should be delivered essentially 3 to 6 months, usually after the last lot of chemotherapy has been done. So that visit, when you come back after the last lot of chemotherapy, and hopefully everyone says all's good, your scans are clear, and that's where we sit down and look at survivorship care plans. Unfortunately, this is very rarely done because there are just not the resources in any of the hospital systems. These are not funded, they're not supported, they're not given through any of the majority of the health service systems, and that makes it really hard. We're certainly something we're rolling out here, but it's been very difficult to do because it's not resourced. The care plan is patient-centred. It really is about enhancing communication between the treating team, the patient and the GP, and creating that triangle with the fourth person being either the nurse coordinator involved in the acute care or a survivorship coordinator, depending on the different setups and hospitals. And so with that survivorship care plan, that should ideally have a treatment summary, so be very sort of didactic around what treatment you had, what doses you had, so that there's that summary is there, so that if you end up moving house or on holidays or something, someone has got a clear record of exactly what happened, and that's important. There should be a follow-up plan. How often are you coming back? Where are you coming back? What's expected? Are you expected to have scans or blood tests, and why? And also a post-treatment care plan. So what risk factors are there? What can be done about it? What should be done about it? For example, having echocardiograms X years later, or blood tests this often, for example. Survivorship care plans should be a fluid document. They'll change over time. Sometimes people need more lymphoma treatment, and so we'll add to that care plan. Sometimes people have risk factors that come and go. We'll change that care plan, for example. But survivorship care plans have been demonstrated quite clearly to reduce anxiety, increase satisfaction, and increase survivor knowledge and communication. But they've also promote lifestyle and behavioural changes. If you understand why it's important to stop smoking, or why it's important to keep fit and healthy, or why it's important to have skin checks, people are much more likely to do it. And that's important because that actually results in less long-term effects, less long-term cancers, less long-term problems, and that's really important too. So a treatment summary would look a bit like this. It would have a diagnosis, a date of treatment, tumour characteristics, so the important things about the actual tumours, the lymphoma that you had. This is a sort of a general cancer one. What the treatment history was, surgery, chemotherapy, radiotherapy, any persistent symptoms at the end of treatment, any other hereditary or genetic risk factors, what sort of services have been provided, so psychosociological support as well. What are the contact information? So key contacts, with a number for the nurse coordinator, the number for the survivorship planner, for example, that sort of thing. And identification of who the key point of contact is for continuing care, because sometimes, depending where people are treated, there's a change from an acute team to a more follow-up team, for example, at various points. And that's important to know who to contact if there's a problem. Is there any need for ongoing treatment? So, maintenance treatment. So when we talk about, for example, say follicular lymphoma, where there might be 2 years of a maintenance treatment, these would often be created at the end of the intensive treatment. And so people might be having ongoing lymphoma treatment. What are the goals of treatment? What were the treatment related side effects? We put in what are the patient priorities and personal goals, and what is the schedule of follow-up visits there. We also then add in what are the possible late and long-term side effects, what symptoms or signs should be watched out for. Ideally, financial, psychological concerns should be addressed as well. There should be recommendations for healthy behaviour, so this could be losing weight, stopping smoking, keeping fit and active, those sort of things. Genetic counselling, prevention, and referrals, and then resources. So as you can imagine, the time and effort to put an individual plan together for any one patient is many, many hours. And it's just not fun. It's just not the ability for most centres to do it. But I would strongly encourage everyone to get at least the very core information for themselves by sitting down and talking to their team. And it's not that this all has to be done in one visit either. It's something that can be chunked through at multiple different time points if needed. So these should come in as an end of treatment discussion with the treating team. They're a live document, fluid document. It's a roadmap, not a rule book, and that's important too. So it's there to guide. It's not a set of rules you must. It really is around communication. If your GP knows what's going on, the GP is your number one ally in getting your health on track for the rest of your life. And it's also a reminder to continue with general health being. So one of the common misconceptions, particularly in younger people who have cancer, but also really can occur at any point, is that once you've had cancer, you've had your cancer. It's kind of like a get-out-of-jail-free card. Yeah, hey, had my cancer, all good. But unfortunately, the bowel cancer, breast cancer, prostate cancer, all common cancers in our community, and it's really, really important to continue on with the regular screening. Have pap smears, have breast screen, have the bowel check at the age of 50. The government sends you a little bowel check in the mail. Be sun smart, diet and exercise, don't smoke, all those things, because unfortunately life goes on and there are those risks. So it's really important to remember all of the good, cancer screening. Have your flu vaccination every year, things like that. Health prevention, is important. And in fact, there are studies showing that in cancer survivors are some of the worst people at general health prevention because their focus is skewed. Rightly so, but it's important to keep back on track. So I think this is my final slide. This is what I think every survivor should know. So it's really important to know what cancer did I have, and that may sound a little funny to some of you, thinking, "Oh, who doesn't know what cancer?" But actually, some people don't really understand exactly what cancer or what lymphoma they had. So it's important to know that. What chemotherapy did I have? Get it written down. What kind and how much radiation did I have? What kind of late effects did I have? And these are all questions you can ask, directly ask. What can I do to live a long and healthy life? I think that's probably one of the critical questions you can ask your doctors if you're a survivor of cancer. What can I do myself? Take charge. Be in charge of your health. And what can I do? And then who can I contact? Where can I go for more help, more resources, more information? Who can I call? Who can I go to? Not every treating team is going to have the time and resources to create a very detailed plan. And I think that's important to understand. As much as we would love to be able to, we would really like that. But over time, and most people are seeing their doctors reasonably regularly, you can get most of that information with some key questions that will enable you to go on and live the best and healthiest lives you possibly can. And I think, just a summary slide. So there are lots of cancer survivors out there. Surveillance and prevention is really what it's all about with late effects. And some effects are very treatment specific, others are very general. And treatment of primary cancer, and this is where we're going now, is that when we're looking at new treatments for the first cancer, the first lymphoma, it really is considering what the late effects could be in the long term, and can we minimise the treatment now to prevent those late effects in the future? And that's very much a goal of the treatment. So where the treatment and the information you're seeing in the long term from people who were treated 10, 20, 40 years ago doesn't reflect treatments now. So thank you.
Thank you, Kylie. That's fantastic. And it's a lot of great information there that we need to learn.
I can leave the slides.
Oh, that'd be fantastic with the slides, and it'll also be filmed as well. And just a couple quick note, we do have diaries outside, which can be quite helpful to be able to write your treatments down and what you've had, contact details of your medical team and things like that. But also the Australian Cancer Survivorship Centre, which is based here at Peter Mac, but it's actually a national team. They have templates for survivorship care plans, and also from the Hodgkin lymphoma and diffuse/B-cell lymphoma, there's like a guide pathway of what you can do for follow-up care, and also some great other resources too. A couple of hands in the air.
Thank you very much. That was great. I'm pleased that your colleague mentioned the survivor plans. Yes. I'd love to have a copy of those lists you had, the treatment summary sheets.
Yes, I'm just saying to Donna, I'm happy to have my slides.
That would be really good, especially those ones.
And also they'll be on the video.
Yeah, if we're going to drive it ourselves, it would be useful to have those things. Yes. Thank you. So who do I pass?
Or I can even create I'm happy to do a printout or a PDF of a couple of pages if that makes life easier for, And the Australian Cancer Survivorship Centre has all of those on their website too.
Good morning and thank you. I noticed you had the sarcomas up there. Does the avascular osteonecrosis come into that?
So avascular necrosis is a complication where the blood supply doesn't get to the bones and the area of bone dies. That's quite different to a sarcoma, which is a cancer of the bone, so completely different. So avascular necrosis is a rare complication of lymphoma treatment, mostly radiation, but can be from chemo too, but doesn't relate to sarcoma. That's a different. Sarcomas usually occur if bone was radiated, usually at a young age, and that's a long-term risk. Yeah.
Okay, because the reason I'm asking is we've got our son just went through chemotherapy, not radiation, last year, and he's now going through the necrosis.
Yes.
All that now,
Yeah.
and I just didn't see that as a...
And much more common in people who are treated as children or young adults.
Young adult.
And the problem is because the bones are still growing, and that's where you end up with the problems, whereas the bone problems are quite uncommon for people who are treated as adults. So, yeah.
Okay, thank you.
Any more questions? No questions. You must have answered all the questions, Kylie. Look, you mentioned also peripheral neuropathy as well. It can be quite uncomfortable, obviously,
Debilitating, yeah.
very debilitating. You get any suggestions for patients who might help with symptoms? I know it's very hard, hardest to treat, really. Yeah.
So peripheral neuropathy is really tricky. So I'll talk from two perspectives here. So the first is, as a doctor, we see it quite commonly. There's a huge range of peripheral neuropathy from people who just had some tingling, numbness, and tingling, numbness, and some, and it's annoying, right through to painful peripheral neuropathy. So some people who really struggle to walk, for example, because they're really painful on the soles of their feet and it feels like they're walking on hot coals or needles or things like that. First thing is probably, mention it. So the main thing is, the first thing is mention it. If you're still having treatment, mention it early, so we can stop the drugs that cause it, which is the first thing, prevention. Once it's occurred, it's about getting it accurately assessed, so getting a referral to a neurologist, getting nerve studies, working out if there's anything particular that's reversible. Unfortunately, there's often not. And then it's about getting a plan for treatment. So it's usually around drugs such as Lyrica, amitriptyline. There's quite a few different drugs we can use to help with it. There's no magic fix. It's one of those things that can be quite difficult to treat, a bit like, fatigue. They wish we had a pill or a tablet or something like that. There's no magic fix, and it's about working around the best way to do that. The flip side of that, I actually had leukemia when I was a kid, and I've got peripheral neuropathy. And what I've found, so I have no feeling in my fingers mostly it affects, and so I can't actually feel things with my fingers, and I have no temperature sensation in my fingers. So, I've developed workarounds. I can't do up buttons easily. I buy things with no buttons or big buttons. So it's about workarounds. I can't feel the temperature, for example, of food. So when I had young children, I could use my elbow or my cheek. I'll bring things up to my cheek to feel the temperature or another part of my skin. So it's just around because I can't actually feel temperature with my hands, for example, things like that. So, and you have to be very careful because I've burnt myself more than once because I can have my hand on on something hot and I won't actually know it until it gets through to the next layer of nerves. So, for example, it's really important to know and understand what your limitations are, because some things, like for me, I had treatment when I was 15 and I'm now in my mid-40s, and so it's just about, and that's never going to get better. So it's about knowing what your limitations are, working workarounds with that, and how to, and fatigue's a lot about that too, things like workarounds and stuff like that. So it's important to sort of just know how you can manage your own problems and turn them from a disability into just a challenge for everyday life, I think. Yeah.
Good morning, thank you. Just in relation to the neuropathy in the fingers, I'm just wondering, once you have got that condition, does it stay the same as it is, or does it get worse in time? I've had it since my last treatment, so I'm probably about 6-7 months in, and I'm finding that some days are worse than others, some hours of the day are worse than others. So I'm just wondering, in time, will it get worse or will it stay pretty much where it's at?
Most people, it doesn't get significantly worse, but it does, as you say, fluctuate day to day, and that's quite a common pattern, that things fluctuate. Almost a lot of these things fluctuate day to day, but it doesn't. usually get a lot worse, particularly once you get out to about 12 months post-treatment, because the nerve damage is caused by the chemotherapy drugs, and the chemotherapy drugs are out of the system very quickly, usually within 24 to 48 hours after they've been given, and the damage is done then. And so then nerves, unfortunately the problem with nerves is they don't repair themselves very well, and that's the problem. So usually by about 12 months, what it is what it is, unfortunately.
So you know what you're left with at that point?
Know what you're left with,
Thank you.
And that is what it is. And, you know, it's a really difficult thing, and it's something that, you know, obviously we'd love to be able to give cancer treatment and cure people without any side effects in the long term, and hopefully, you know, as we're changing, we're getting better and better at doing that. But you have to survive your cancer to get long-term side effects, and that's the catch, you know, and that's the tricky catch. You know, to get your second cancer, you have to survive your first one, and that's what's hard. Nobody wants to tick them off, you know, but and that's the tricky thing. Yeah.
Thank you.
Got time for one more quick question.
Thank you. We're looking for a little bit of guidance about recovery of the immune system after R-CHOP therapy.
So it's really important. So the immune system is damaged by any chemotherapy. So the immune system is a very complex, multifaceted beast, as it was. You've got what's called cellular immunity, which is the cells that fight infection, and humoral immunity, which is the proteins effectively, or the hormonal sort of component of immunity, and they work together, and both can be damaged by the effects of chemotherapy. Most of the immune system recovery occurs by about 12 months, but then it's about your immune system re-exposing itself. So, you know, once you've had it, essentially your body develops from a very, very young age a memory of the bugs that it's seen and the insults that it's seen. So you think about, you know, when you send your kid to kindy or to daycare for the first time, they come home with a new bug every second week, right? And school and all those things. When you've had leukemia or lymphoma treatment, chemotherapy of any sort, you're almost resetting back to that level. And so it is important over time, your body, you will in the first few years get a lot of colds and bugs and things like that again. And that's your body building up its own natural immunity. For some people, that doesn't occur quite as well as it should, or some people have low effects. It's very important to talk to your individual doctor about that, because there's some specific problems that can occur. The most common is low immunoglobulins, and some people need angiogram or immunoglobulin infusions regularly, monthly, going forward. But it's about, you know, monitoring that, and it's very specific, patient specific. So there's no sort of blanket fix for that. But the immune system is low, and it just needs to take time to build up, and it will take, you know, probably 2 to 3 years plus to build up over time, at least. And even then, if you think about it as children, you know, at what age do children start to become more robust and not come home with a bug every week? I've got an 8-year-old and an 11-year-old, and it's getting better now a little bit. So it does take a long time, for example. You know, it's hard.
It's also quite alarming for a lot of patients when their lymph nodes start swelling with these infections too, which quite often is your immune system doing its job. Yeah.
Yeah.
Sort of questions I get. But thank you so much, Kylie. That was fantastic. We talk about this all day. Please join me in thanking Kylie for a fantastic presentation.
Thank you. Thanks.